Today's session is going to be a fun, interactive, case-based session by Dr. Sabahat Ather. Dr. Ather completed her radiology training in Pakistan and moved to Saudi Arabia in 2015. And she's a practicing staff physician at King Abdul Aziz Hospital. I don't know how many of you participated in our grand quiz for a cause program a few months ago, but Dr. Ather's talk was one of the most captivating talk during that session, and I'm sure this session is going to be similar. Without wasting any further time, I would request Dr. Ather to start sharing her presentation and start sharing her session today. Over to you, Dr. Ather.
Okay. Thank you very much, Dr. Amar, for giving me an opportunity in the radiogan session. And let me tell you, you guys are doing a fantastic job and helping out radiology residents all over the world, doing all sorts of board exams. And to have an access to free online education like this, it's truly, invaluable. Thank you for letting me be a part of it. So today we are going to do case-based radiology. I think there is no better way of learning radiology rather, taking the case and few take-home points with it. So I'll start. The cases I have are nothing complicated. They're everyday cases. They're on-call cases, and they're cases which have clinical, background or importance. So let's start with an easy one. Okay. So what do you guys think? Okay. This is what happens. We do it every day. And endotracheal tube, yeah, it is actually, there is a tracheostomy tube. So what do you think is happening? No trauma history. This is just an ICU patient who has come in for a routine chest X-ray. Okay, let me show you. Can you see my arrow? So this is the tracheostomy tube, right? Now, can you see the NG tube? I hope my arrow is visible. Where is the NG tube going? The NG tube is going in the left lower lobe bronchus. Can everybody see it? This left lower lobe bronchus, the endotracheal tube is going. So this is misplaced tip of nasogastric tube. So what do you do regarding this patient? You saw this case, what do you do? We are going to, yes, NG tube in the left lower bronchus. And what will you do? Once you see this thing in the exams, when you see this, when you pick this finding, do not wait for the examiner to ask you what to do next. You say, I can see that the NG tube is in the lower lobe bronchus. Yes, urgent call to ICU. Exactly. Okay, let's go to the next case. So never forget the management. That is the thing. And always starts with the lines and tubes. You see, lines, and it's very important, especially in the exam setting, to be systematic. Otherwise, we would forget. So always start with the lines and tubes. And once you see the lines and tubes, once you say that the endotracheal tube is in the left lower lobe bronchus, go and say that I would pick up the phone, call the ICU, and then go to the rest of the cases. Okay? Well done. Case number 2. This is just to show, because, there are so many medical advances happening, not only in radiology, but also in other cases. This is just to show, do you know which device is this? If you have an abdominal X-ray, you will have to mention that there is a device here, right? So what do you think this device is? Okay, let us proceed. This is spinal cord stimulator. Okay, this is going into the spinal canal, into the epidural space. See, so this is spinal cord stimulator, and this is being used in patients who are there with chronic pain. For pain management symptoms, this is being used. So this is a spinal cord stimulator to help with symptom relief in individuals with chronic neurological pain. Okay, so let me show you again. This is a spinal cord stimulator, which you will see in patients who are being managed for chronic pain. Okay, let's go to the next case. What device is this? yeah, we don't see it very often. So maybe it's, okay, this is implantable loop recorder. Implantable loop recorder, what it does is, this is subcutaneously again placed, but it is going to record the rhythm, the cardiac rhythms, okay? And it is used for the evaluation of patients who have recurrent unexplained episodes of syncope and palpitations. So this is let's go back again. When you see this USB device, it's long gone. We don't have any more USB device like this, but you might think, oh, does this patient have a foreign body in his pocket or something? And you want to go and scream at the technician. No, this is an implantable loop recorder, okay? Okay, now marching on to the case number 4. So what's happening here? This is an X-ray, abdominal X-ray from the ED. And the surgery is also there. So this is an abdominal X-ray, erect position. What are we seeing? Excellent, pneumoperitoneum. So if it's an adult patient and there's a pneumoperitoneum, and what is the first differential which comes in mind? The surgeon is quite confident on his clinical examination and on the X-ray, and he's about to take the patient to the OR. Excellent, perforation. And you know, these are one of those moments when you really feel happy with the surgery on call and the ED, because they are taking decisions on the patient history, on their own examination, and on the X-ray. So this patient was taken to the OR, and it was a case of duodenal perforation because he had gastritis. He was a known of case of gastric ulcers. So these are one type of X-rays, EDs, and on-call cases you have. The next case, you know, I will remember this case for a very, very long time. You know, of course, when you are on call and with the emergency department and with the on-call team, you have all sorts of experiences. So this is one of my on-call nights, and we are having a tough time, and we are tired of doing all the ultrasound abdomens and CT brains, which are coming as negative, negative, negative. And then the ER physician calls me and tells me that we have a patient, I believe in middle age, 40, 45 or 50, and he has testicular pain left-sided for 4 days. We want testicular ultrasound. And we had such a long argument. I was like, if he has testicular pain for 4 days, if it's torsion, the testis is gone, okay? And if it's epididymoarchitis, it can be managed tomorrow on OPD basis. Why do you need a testicular ultrasound? And he was adamant, and I was adamant. And after a long discussion, I wanted him to get convinced to get it not done, and he was not willing to budge. So we ended up doing it. Once the patient was in the room, the ultrasound tech called me to see the case. And when I entered the room, guys, it had such a pungent smell. And it was hard to even scan the patient. So these are the selected images. What do you think is happening here? I'll wait for a few seconds. Go ahead, tell me that what is happening in an ultrasound testis, which we have done. Okay. Okay. Any other guesses? Excellent. That's what was happening. You see, this patient had Fournier gangrene. What we are seeing here, he had diffuse scrotal wall edema. He was oozing pus. And if you can see here, these are all air foci with very dirty shadowing. And this is a collection here. And it was one of the, you know, it's been a long time that I saw this Fournier's gangrene of this extent. And this just gives, you know, Fournier's gangrene, as you know, is a necrotizing fasciitis of the perineum. The skin is edematous, filled with gas foci, and this is a urological emergency. And this patient was immediately taken to the OR with a urologist, and debridement was done. The lesson, what I want to tell you here is that you will have all sorts of, you know, experience, all sorts of ED experienced doctors. And this, at times, it's not your fault, but things can get complicated once you refuse the case and because of the clinical misjudgment on the part of clinician. But when medical legal cases get dragged on, everybody is pulled in. So that is why I remember this case for a long, long time. And it's one of the most permanent cases of Fournier gangrene. You can see the patient was taken to OR and debridement was done and he was fine. Okay, moving on. What can be the typical name which we use when we see such advanced cases of RA? Okay, so what we are seeing here is a case of arthritis mutilans. Okay, arthritis mutilans can also be seen in psoriatic arthritis, but here we can see that this patient has diffuse osteopenia. He has erosions all over the place. He has diffuse joint space narrowing, the radiocarpal joint, the intercarpal joint, the metacarpophalangeal joints, the proximal interphalangeal joints are involved. And we can see the amount of subluxation and at the metacarpophalangeal joints of the ulnar deviation. Okay, and you can see the flexion deformities as well. And of course, as you guys are mentioning, botanier, swan neck, hitchhiker, these are all different deformities which you see in advanced cases of rheumatoid arthritis. Now, usually the rheumatoid arthritis cases start with juxta-articular osteoporosis. But when it is advanced, because of the treatment and the steroid treatment, it leads to diffuse osteoporosis, as we are seeing here in this case. Okay, so very well done. Yes, this is rheumatoid arthritis, arthritis mutilans. And as I said, it's a bilaterally symmetrical disease, typically metacarpophalangeal, PIP and carpal, erosions, joint space narrowing, and in late stages, uncommonly, it can cause ankylosis. Now, just a general review, how do we approach the arthritis? You know, the good old ABCDEs, which never gets old. Whenever you see arthritis, you have to look at the alignment, you have to look at the bone mineralization and production, whether there's erosion or whether new osteophyte formation, you know, those seagull wings, or the mouse ear, all these you have to see. The cartilage joint space calcification, whether there is joint space narrowing, whether there is chondrocalcinosis, whether there is soft tissue calcification, the distribution, proximal or distal, okay, erosions, and soft tissue swelling. So this is how, in general, you should always approach a case of arthritis to reach, an ultimate differential diagnosis. Okay. Going to the next case. This patient came with pain. What he has pain, let me show you. He has pain in his right fourth finger. So we are going to go, if you cannot see the pathology immediately, you go systematically, okay? Anyone has found anything? Right fourth finger. Okay, maybe it's a projection. Let me give you a close-up view. Now tell me what is happening here. See calcifications, okay. So if you see here, you know, can I convince you there is a well-defined lucent lesion involving the proximal phalanx, right? And there are chondroid calcifications within. Excellent. You have a discontinuity here along the cortex, which has led to fracture, and hence there is this pain in this patient. So as everybody said, excellent, this is enchondroma. Very good. So this is enchondroma. What is Ollier's disease? And what is Miffucci's? These are the two things which you should know whenever you come across an enchondroma. Yeah, there is a pathological fracture. Excellent. So the Ollier's disease is I think there must be some lag in between the chat. So I would go on. Ollier's is multiple enchondromas. Excellent, excellent, Dr. Ram. Now, Miffucci would be. So in your exams, when you are talking about enchondroma, do not forget to give the negatives. So I can see only in solitary enchondroma. I do not see any other enchondroma in the present study. Okay, and then you will also say that there is no soft tissue calcifications. Why? Because if there is soft tissue calcification, there is hemangioma, there is Miffucci's. Excellent. Yes, everybody got it. Excellent. Next case. No, before the next case, let us see how to evaluate a bone lesion. You know, whenever in the exams, you have quickly picked up that this is an enchondroma. You have no doubt about it. But everyone, and even in your everyday practice, you should be able to define it properly. Okay, you have to you should be able to say whether this is unfused or fused skeleton, whether it's a degenerative skeleton, where is the location, the phalanx, the spine, the metaphysis, the epiphysis, the diaphysis. All this is going to hold importance, whether this is solitary or multifocal. Okay. Matrix and mineralization. Okay, this is important. Matrix is that whether it's osteoid or chondroid matrix. Okay, and mineralization is whether you are having calcification along of the lesion itself or around the soft tissues. Zone of transition, very important. Narrow zone of transition is where you can draw the lesion with a pencil. This is the previous case which we saw was a narrow zone of transition. Wide zone of transition, when you do not see the transition discretely, that is an aggressive lesion. It could be infection or it can be neoplastic, malignant neoplastic, periosteal reaction, sunburst, lamellated, onion peel. All this is going to be important. Size. Why size? For example, fibrous cortical defect versus non-ossifying fibroma. Less than 3, more than 3. Osteoid, osteoma, and osteoblastoma. Less than 2 cm, more than 2 cm. So size gets important. Okay. Okay. How to tell osteoid or chondroid? Okay, osteoid and chondroid, you are going to go with the matrix. Look, the chondroid would have, I'm sorry, I'll have to go back. The chondroid will have, very soft tissue, very chondroid type. The density is less than what you see in the osteosarcoma, for example. In osteosarcoma, the matrix is predominantly calcific, like the bone. This density is less than the adjacent bone. It is less than the adjacent bone. That is why it's chondroid, and it's soft, and it's like arc and ring. So that is how you call it chondroid matrix. Okay. Okay. Now, case number 8. This patient has presented with a lump. He feels a lump in his back. What do you think is happening here? So what we see here, if I would describe it, it's a very well-defined lesion. It's hypoechoic. It does not have any vascularity. It does not seem to invade any adjacent structure. There does not seem to be any alteration of the echogenicity of the surrounding parenchyma. So what do you think it can be? Okay, what else? Good pick, good pick. Okay, so we did an hematoma is also a very reasonable differential. But you see, I have given you a location. It's the technician has written that it's in the posterior lower chest. Actually, it's at the back, posterior lower back. Okay, let me show you the CT which was done in this patient. You see, this is the soft tissue density which we are seeing on the ultrasound. Lipoma. Yeah, this is also one of the differential. Now let's see what this is. Some of you got it right. So let's see what is happening here. On CT, we are seeing a soft tissue density lesion. It's ill-defined and it's infrascapular. Okay, this is the end of the scapula. So this is infrascapular. This is deep to the serratus anterior and the latissimus dorsi. And you can see a large soft tissue density here, and if you look on the other side, you will see a faint soft tissue density here as well. Okay, you can see a soft tissue density here as well. So this is bilateral, very large on the right side, on the left side, sorry, on the left side. It is deep to the serratus anterior and the latissimus dorsi. It is infrascapular, as people said. This is elastofibroma dorsi. And once it's in typical location with typical appearance, there is no other diagnosis for it. Okay, it's like the Aunt Minnie. Now, a few things which you should remember about elastofibroma dorsi. As I said, characteristic location, infrascapular, deep to the serratus anterior and latissimus dorsi, and it does show mild to moderate uptake, FDG uptake on PET-CT. So please do not get it confused with a malignant lesion, with something sinister. No, it's not. They do end up showing mild to moderate uptake, elastofibroma dorsi, and it's a totally benign pathology. Okay, going to the next case. Okay, So this is a child, and I'm showing you 3D images. No, not sinus pericardiae. Just concentrate on these sutures. Leave these are artifacts. Excellent, excellent. People got it. So this is scaphocephaly. These, I understand people are saying it LCH. These are just the reformatting errors. The main thing which we are seeing is the fusion. This is the fusion of the sagittal suture. This is a child in the initial few months. So these sutures are not widened. This is how they should be. But this is for the comparison that how the sagittal suture is fused. So this is scaphalocephaly or dolichocephaly, okay? So just a few quizzes. Once you have a craniosynostosis, you should know what other synostoses are, okay? So what do you think brachycephaly is? I'll wait for a few seconds, otherwise we'll go ahead. Okay, let me proceed. It's when we have the fusion of the bicoronal or bilambdoid suture, okay? That is brachycephaly. Plagiocephaly is when you have unicoronal and coronal and lambdoid suture, like a flat skull on one side. Trigonocephaly is when there is metopic sutures, right? Harlequin eye is when you have an ipsilateral coronal suture fusion. Oxycephaly or tower skull, when you have sagittal, coronal, lambdoid, all of them are fused. And the severest is the cloverleaf skull, when intrauterine there is fusion of all the sutures. So this is the most severe, okay? So this is the craniosynostosis, which we can, which is this case, and that case was of sagittal suture fusion, dolichocephaly, okay? Let's go next. So this is a female patient. And go ahead. What do you think is happening here? So this is ultrasound renal, both the kidneys. Do you think anything away from the normal or something different from the normal? Excellent. So what you can see is that the cortex, you can very finely see the cortex. The cortex looks fine, but the medulla is echogenic. The medulla is echogenic. It's triangular, okay? It's triangular. So the terminology for this would be medullary nephrocalcinosis. This is medullary nephrocalcinosis, the feature. Now, what are the differentials of medullary nephrocalcinosis? As somebody said, medullary sponge kidney, yes. This particular patient was a case of renal tubular acidosis, okay? But as mentioned in the chat, yes, medullary sponge kidney, hyperparathyroidism, these are other causes of medullary nephrocalcinosis. Well done. Okay, marching on. So what is happening here? I'll wait, I'll give some time. I think there is some lag for the chat. So I will give some time for the candidates to see this case and tell me what you think. So this is a bone scan. We have anterior and posterior views. Excellent, yes, excellent. So this is a super scan. Why are we calling it super scan? Because these are one of the very frequently asked exam cases in all type of board exam. So why are we calling it a super scan? Yes, diffuse uptake, agreed. What else? What is the giveaway point for the super scan? Kidneys are subtracted. Excellent. These are absent kidneys. You do not have any kidney where you should see it, right? So this is the absent kidney sign, and hence this is a super scan. So what are the causes of super scan? Very well done. As usual, the RadioGyn audience is so enthusiastic and full of energy. Excellent. Now we are coming to the causes of super scan. What do you think? If I say this is a male patient, so what is the cause of the super scan here? Okay, I think again there is some lag of the chat, so I will proceed. So this is, you can see that there is diffuse uptake, as everybody said, absent kidney sign in the skull, in the axial skeleton. You see this bow tie sign of the sternum, the spine, the pelvis. Prostate cancer, yes. This particular case was a known case of prostate cancer. And as people rightly said, there are multiple other reasons of prostate, super scan. In metastatic, of course, prostate, breast, leukemia, lymphoma. But then there are metabolic causes as well, right? As somebody rightly mentioned, renal osteodystrophy, hyperparathyroidism, osteomalacia, myelofibrosis, Paget's disease. These are all causes of super scan. Now, the next thing which might come, ideally speaking, how to differentiate between metastatic and metabolic. So metastatic, when you have metastatic, it is usually a diffuse uptake along the axial and the proximal appendicular skeleton, okay? The proximal appendicular skeleton and the axial, while metabolic would have diffuse uptake involving the extremities as well, and calvaria as well, and mandibles as well. But as you know, things are always not very perfect. There can be overlap as well, for example, the one we had in this case. But if you go into the textbooks, ideally speaking, the metastatic super scan would have the axial and the proximal appendicular skeleton predilection, while a metabolic one would have diffuse uptake involving the peripheral skeleton as well, and the mandible and skull. Okay, very well done, everybody got it. Okay, let's go to the next case. What's happening here? As I said before as well, always in an X-ray, we should start with what? Pneumothorax. Okay, what else? Tubes, excellent. So what do you think of the tubes? What are the tubes here and what do you think, how are they? I will wait for this one because these are one of the very important ones. And you know, sometimes the examiner will put these only for the case of tubes. He will not care whether you pick up the RDS or not. But yes, there is endotracheal tube, there is umbilical venous catheter. What else is there? Oh, sorry. What else is there? Okay, let me show this. So this is the endotracheal tube, right? It seems quite close to the carina. Then what do you have? The nasogastric tube. The nasogastric tube seems okay, right? Then I come here. You see this line? Follow the line. This is the UVC. This UVC is going to go straight up. And the tip of the UVC should be at the junction of the right atrium and the IVC. In that sense, this is fine. Okay? Next, you have the umbilical arterial catheter. Now, how to differentiate between an umbilical arterial and umbilical venous catheter? The umbilical venous catheter would go straight, while the umbilical arterial catheter will take a loop because it would go to the iliac artery and then go up. So whichever catheter is taking a loop in a pediatric X-ray is the umbilical arterial catheter. Now, umbilical arterial catheter would have two positions, low position or high position, the expected positions. The aim is to avoid the major branches of the arteries, okay? So this the umbilical arterial catheter is between T6 to T10. That position should be fine. And low position is L2 to L5. What you want to do is to avoid the major branches, the celiac, SMA, and the renal and the IMA. I'm still looking for someone to tell me another finding, which is here. Or maybe it has gone pneumoperitoneum. Excellent. Why? You see this whole lucency here? This is a whole lucency which you can see. And when you do the decubitus, it becomes very evident. So this is a case of pneumoperitoneum with UVC, UAC, endotracheal tube, NG tube, and everything would need to be mentioned. Okay, now this is another baby which has an additional finding. He has pneumoperitoneum, okay, but I want you to tell me something else here as well. You can see this lucency overlying the whole of the abdomen. You can so clearly see the regular sign. You can see both the walls of the bowel loop. What else you can see? Yeah, there is football sign, I agree. But do you see anything else here? Can you see it? Okay, let me put it this way. Can you see the extension of the pneumoperitoneum? Where is it? Ah, air in the scrotum. Excellent. Yes. So this is air in the scrotum. It is a very simple finding, you might say. But at times the examiner is waiting for you to say this. Do not presume that other person knows it. Do not presume. Describe everything. Describe every catheter, every line, and mention all the extensions. So rightly said, very well done that there is air in the hemiscrotum as well. As I said, UVC tip position, the umbilical venous catheter should be at the junction of the venous IVC with right atrium. And the UAC tip position, it can be high, T6 to T10, and low position L3 to L5. Okay. Moving to the next case. Yeah, there is RDS. Yes, NEC, one of the causes of pneumoperitoneum. Now, let's go to the next case. You can see in the images that this is the uterus, right? So have a look. I'll give some time. I can see that there is a lag. So I'll wait for some time for you guys to type in your answer. What is happening in this ultrasound, which is showing you a uterus? Excellent. Everybody got it, I think. Everybody got it. So what you can see is an enlarged uterus with an intrauterine mass with cystic spaces in between, with some vascularity. And you can call this as a bunch of grape signs. And as people, all of them mentioned that this is molar pregnancy. Excellent. Well done. What happens in molar pregnancy? Your labs would be an excellent indicator. Now, this patient has the HCG going through the roof. She was a gravidus 7 para 5 plus 1 and 10 weeks, 4 days. So naturally, if you are not seeing any sac, you're not seeing any fetal pole, then you are concerned, and the patient underwent dilatation and suction, and this was complete hydatid-form mole. Well done. Okay. So the classic words you should use should be snowstorm and bunch of grapes type appearance. Okay. Next case. A child. What's happening here? You will inform the pediatric surgeon, okay? This patient, it's not an AVN, I think it's projectional. The finding here is metallic foreign bodies. The child actually ate up 14 magnetic beads, 14. And you can see that this is all they are joined with each other. The pediatric surgery wanted to go in and take it out. Of course, there are two options, conservative and surgical, but the parents insisted on surgical. Yes, informed pediatric surgery, excellent, and surgery, and that is what they were offered. But the parents were reluctant, and they said, let us see conservatively, maybe it will come out. Now, what is happening here after some time? Now, this is alarming, because it's not that only it has changed its position, it has descended down. Basically, it has become in the form of a circle. Now the pediatric surgery pushed the parents that it has the baby child has to go to the OR, and they took out 14 pieces of magnets, and there were 5 perforations. So at times, even when you know what is the right management to do, you cannot manage the patient without the consent. And as the parents were not ready to give the consent, the poor child had an extensive surgery, but was fine later on. Okay, so well done, everyone. Everybody picked it up. Now, this is an adult male who has come with lower abdominal pain. What do you think is happening here? I have two images. This is coronal zoomed up image of the pelvis. And the other one is the axial image. I'll wait for the chat to come in. Excellent, diverticulitis. I know you can see multiple divertically. You can see a lot of fat stranding. You can see the soft tissue thickening, right? And even here, you can see that how the infiltration is there. Do you see something else? Yeah, sigmoid diverticulitis, agreed. But do you see something else? I'll flip between the two images again and again, because I want to see you something. Sigmoid diverticulitis, perfect, but I want to see you something else as well. It is subtle, but once you see it, you will be, yeah, complicated diverticulitis. Okay, we did not have any collection, but okay, I'll take it. No, it's excellent. Somebody said IUCD, but no, this was not IUCD. There was no abscess. Yes, wall thickening was there. I agree. Fistless communication. With what? Blush. I totally understand where he's saying suture. Excellent. Okay, so what you're calling suture and what you're calling active extravasation, because this structure seems very, very similar to the contrast. So it's a bit, tricky. But when you change the density, can you see this linear object here? No, there is no fistula. This was a male patient, so no IUCD. Can everybody agree that there is a linear body here? This was a linear foreign body in this patient. The patient had diverticulosis, he had diverticulitis, but it was complicated by the foreign body. And this patient underwent colonoscopy, and what they took out was a chicken bone. So guys, all of us, when you eat McDonald's and KFCs, take out the bones. You never know where it ends up. There was no fistula to the urinary bladder. Of course, it is difficult to say because of the limited images, but the final diagnosis here is that this was a patient of diverticulitis who had a linear foreign body, which was actually an impacted chicken bone, which was removed on colonoscopy, and then the patient was treated conservatively, and he was fine with it. So it's one of the very interesting cases which we had in our department, okay? So let's go to the next case. I have two images from this case. So I'll wait for the chat to come in. Excellent, everybody got it. Excellent, bezoar. Okay, that's a perfect answer. Phytobezoar, excellent. So what do you think, why this patient has bezoar? Do these images give you an indication for the reason of this gastric bezoar? Let me shuffle in between the two images to give you some time to see the case and tell me that why this patient has bezoar. There are two reasons. Usually there are two sets of cases, two sets of patients where we see bezoar, right? Yeah, we have hair. What else? Hyperdense liver. Well picked up. Let's leave it. Tell me the reason of bezoar in this patient. Psychiatric patients. Excellent. Yes. There is another group of patients who can have bezoar. Excellently picked, said psychiatric patient. Okay, this patient was completely sane. No psychiatric problems. So what do you think is the reason? Excellent. Gastric surgery. Yes. So there are two sets of patients who can end up having bezoars. Okay, this patient had endoscopy, and can you see the extent of bezoar he had. And they tried to, mince the bezoar and tried to evacuate it, but they couldn't. So this patient underwent, actually, unfortunately, he had to go through surgery, open surgery, and had his gastric bezoar removed. So associations, as I said, previous gastric surgery and psychiatric illness. This case, a patient of ours had previous gastric surgery. As you can see that he has surgical staples, right? You can see the surgical staples. So he had previous gastric surgery. And as discussed here, you have trichobezoar, you have phytobezoar, pharmacobezoar, lactobezoar. Tricho is here, phyto is food, pharmaco is medicine, lacto is milk. Somebody asked me how to differentiate phyto or tricho. Honestly speaking, tricho here usually go till the duodenum and the stomach, but 100% answer, I apologize, I don't have to that. This patient had BPD surgery 8 years back. Okay. I thought that I would be out of time, but I still have time, so let me show a few cases. So this is a young patient who had a splenic lesion, and we did CT, and you can see that there are enlarged lymph nodes, para-aortic, aortocaval, mesenteric, going all along the chain. So what is the top differential here? I'll give some time because I can see that there's delay in the chat. Excellent. The top differential would be lymphoma. And you have splenic lesion, you have multiple lymphadenopathies. So and you have in the cervical as well. So this was biopsy proven DLBCL, right? What else can be the differentials down the line apart from lymphoma? Because they can always be surprises. I think somebody wrote metastases. Lymphoma, TB, metastases, these are all very well-valid differentials. Excellent. Okay, now coming to some other interesting cases. I hope that this X-ray is visible to you. And I hope that you can see what I'm trying to show you here. If this is not very clear, let me give you a clue. Just look at the lines. Is there anything wrong with the line on this chest X-ray? Okay. Yeah, I hope is it better now? Okay. There can be some problem with the blurring of the image. I apologize for that. But let us forget about the paratracheal stripe, everything. What I want to show you, can you see the central line? The central line is coming, and it is going there. Misplaced line. Excellent. Misplaced line. This is what we said as well. Yes. And what can be the, if your clinician is not convinced, what can be the easiest way to prove your point? What do you think? Because the line is starting quite high up, right, from the neck. Malpositioned central catheter. Excellent. Everybody got it. Yes. So what do you think? What can I tell them? Lateral chest X-ray. Okay, that's a good option. What else? Fluoro. Okay. Yeah. But then if we have radiation. Okay. Let me try. So what we did the ultrasound here. So when we did the ultrasound, we showed them that this is the CCA and the catheter is passing through the artery. So basically, this was inadvertent arterial insertion of the central line. Okay, so this is one of the ways of doing it. Now, a similar case was presented to us some time later. And I remember very vividly, it was my weekend call and the ICU called me regarding a central line insertion. They said, we are getting arterial readings. So come and see the patient, do the ultrasound and tell us where the catheter is. When we did the ultrasound, of course, the catheter, you see, it's all it was recently done. It was all heavily packed up. We could only scan part of the neck. And on the neck, the catheter was in the vein. And the ICU physician said, I know this is arterial. So what did I say to him? I said, look, I'm not disputing what you're saying, but I'm telling you what I can see on the ultrasound, and on the ultrasound, it's in the vein. So what we did, I can offer you a CT, as was rightly mentioned here as well. So I'm going to show you some images of the selected images of the CT, and tell me what you see. Remember, we are trying to trace the central line. I'll keep it on the first image. Then I'll proceed later. So on the basis of this of the CT images, what do you think is happening? Okay, let me show you. You see, this is the vein, this is the artery, right? This is the vein, this is the artery. So this is here, it's within the vein. And that is what we felt on the ultrasound as well, that the catheter is in the vein. But beneath the clavicle, where is the catheter? Excellent. This has gone into the artery. Do you see? It has gone to the arch of aorta. So basically, when we were doing the ultrasound, we were also correct that in the neck, the catheter is in the vein, but the ICU physician was also correct that he's getting arterial reading. This is arterial. So basically, the catheter went into the vein, but unfortunately, inadvertently, the vein got punctured, went into the artery till the arch of aorta. Now, this was an emergency. The vascular surgeon was there, and immediately the cardiac surgeon was also contacted, taken to the OR, and he was safely, the catheter was taken out, and the repair was done, and the patient was fine afterwards. So these were for a few of the cases of the misplaced. My cases, this was my last case. Thank you so much for being such an amazing audience. My acknowledgement to my department and to Dr. Amar Udare, who keeps an excellent collection of cases for us to present. And thank you very much, everyone. Over to you, Dr. Amar. Thank you, everyone, for being a wonderful audience, and happy holidays, and have a great weekend.
Thank you, Dr. Ather. Those were some wonderful cases, and despite there being a lag, you didn't dampen your enthusiasm. So kudos to you. And most of them were very typical exam cases, and you led everyone gradually approach towards the cases. So thank you for presenting such awesome cases, and thank you for doing this on a holiday. And thank you for everybody who's come here today on a holiday and attending our session. Remember, we do these sessions every Saturday at 8 p.m. India time and 9:30 or 10:30 Eastern time, depending on daylight savings. And do let us know the feedback for this session. You can hit the thumbs up button on the YouTube video. That'll not only help us get feedback, but also help the more such videos you like or comment on, your own YouTube feed will improve. You'll get more relevant radiology videos in your YouTube feed. If you have any suggestions for us, do let us know. We always, we've come this far based on your suggestions and what you would like to have. And thank you, everyone, for joining us again today. Happy holidays and Happy New Year in advance. Bye-bye.
Okay, thank you, Dr.